Hello, I'm Dr. Michael Brad Bayless, founder of Bayless Healthcare. Today we have an exciting program brought to you by Dr. John Barton, who is a professor of psychology at Arizona State University and also a clinician at Phoenix Children's Hospital. Dr. Barton will be discussing how chronic illnesses affect the cognitive functioning in children. Diseases such as epilepsy, cancer, leukemia, and other types of chronic malfunctions. Oftentimes, the cure for these particular diseases, such as chemotherapy, can also affect the way in which a child functions within his normal daily routine. We're excited and pleased to have Dr. John Barton explore this area with us and explain how chronic illnesses invade our children's lives.
Okay, so what I hope to talk about today is how chronic illness affects cognitive functioning in children. Hope you will be able to recognize how cognitive factors affect disease management, relate these effects to school performance, and understand how to help. Now, I tried to base most of this talk on research and reading the literature, and that's always a perilous endeavor, because when you start looking at the research that addresses these issues, you find that there are lots of methodological problems. So the conclusions we can draw about all these things are a bit tenuous. There are problems in measurement, there are problems in subject selection, there are problems in experimental control in many of the studies that I'm going to talk about. So again, take all this with 2.57 grams of salt. And to sort of walk us through this, I will talk about Frank. Frank is a 16-year-old Latino junior in high school. He lives at home with his mom and his sibs. He has a good relationship with his father, though. And mom has some pretty new age health beliefs, which doesn't work particularly well for Frank, as he has end-stage renal disease, and he's been on dialysis for 2 years. He doesn't follow directions about taking his medicine or advice regarding fluid intake and dietary restrictions. And he is on the transplant list, but he's pretty anxious about that. So we'll use Frank as a reference point as we go through this. Some of the mechanisms for that which causes cognitive problems, there are many physiological mechanisms. If organs and systems aren't working correctly, you can have an accumulation of toxins. For Frank, possibly because of his renal disease, accumulation of urea and ammonia may be creating some negative physiological effects. Deprivation of essential nutrients such as hypoglycemia in diabetes or oxygen in heart disease. There is often a cascade effect, so that if one thing's out of whack, it causes derangement in other organs. So for example, if you have diabetes and have lots of hyperglycemia, that can lead to heart disease and kidney disease. In kidney disease, there's also polyuria, which leads to parathyroid problems, and that can lead to abnormal brain function. So one thing often gets into a cascade with problems in other organs. And as I was doing a variation on this talk at ASU recently, I switched the title to, well, I've got some good news and I've got some bad news. The good news is that this treatment works. The bad news is that there are many side effects, such as craniospinal radiation or intrathecal chemotherapy if you've got cancer and leukemia. That's going to cause some serious cognitive side effects. With kids with renal disease, they are taking lots of steroids. Kids who have transplant take lots of immunosuppressants. And these have iatrogenic effects that may cause cognitive problems. When you think about illness and its effect on cognition, there are a number of correlates. Usually, but not always, the earlier onset of the illness, it usually has greater negative impact on cognitive function. Sometimes on emotional function, it doesn't work that way. Kids have said, well, you know, I've never known life without this. This is just the way life is. So I've suffered no great losses, as opposed to somebody who's acquired a chronic illness in adolescence. They know life differently. Usually, the duration of the illness, the longer you have it, the greater the negative impact. But then there's been a meta-analysis that says, well, no, duration of the illness doesn't have any impact on your academic achievement. So here, again, is the perils of looking at conflicting research. The degree of control, usually the less control you have means worse outcome. So early, long, and out of control usually means bad effects for cognition. How about intellectual ability? The effects can range from none to mild to severe. If you've got mild effects, you might have some specific deficits, say in verbal memory or in executive function, and that may not have a profound effect on IQ. On the other hand, especially in early renal or liver disease, you can have some pretty severe deficits with gross and diffuse impairment if you have one of those illnesses very early in life. Sometimes this will prove with your disease status. So if your disease gets better, sometimes your cognitive functioning will improve. That's usually in older kids, and even if they improve, they're still likely to be more impaired than are their healthy peers. There can be effects on verbal functioning, such as vocabulary or for information, and kids with diabetes will often suffer those effects. Verbal reasoning is affected in kids with renal disease. On the other hand, there are also visual spatial deficits. Copying, constructional ability, these things are found in kids with renal disease and diabetes as well. Not surprisingly, things like attention, memory and learning, psychomotor efficiency, and executive functioning can also be affected by chronic illnesses. We're becoming more and more interested in executive functioning, and anybody want to venture a definition of what executive functions are? This is audience participation time now. An executive function might be what?
Reasoning.
Could be reasoning, okay. Planning. Mm-hmm. Either or? Both. Okay. There are lots of definitions of executive functioning. Most of these definitions will include at least response inhibition. If you're going to reason, if you're going to plan, you've got to stop long enough to do that. A child I tested just recently, very poor reasoning, very poor planning because he didn't take time to think about it. And even if we stopped him and sent him back and said, no, stop and think about this before you try it again, still not very good reasoning. The other component is usually goal-directed behavior. So we can think about these as one, including behavioral regulation, including inhibition. You've got to stop long enough for these other executive functions to work. Emotional control and shifting usually fall under that heading of behavioral regulation. And goal-directed behavior or mental problem solving, getting started on a problem, planning and organizing the steps that you're going to take, keeping all those steps in mind, and then being able to look back, step outside of yourself, and look at how you're doing and how your product is. Is this where we all glare?
We stare at the people coming in late.
Okay. Duly noted that the audience has glared.
Keep breathing.
Oh, I'm good. I'm not in college anymore, so.
One of the populations that I've worked with is the epilepsy population. This accounts for about 1% of those kids under 20. It's about 5 per 1,000. And in kids with epilepsy, they have IQs that are normally distributed, although that's usually skewed a bit lower. The earlier onset, the greater the negative impact, as we've said before. And the worse control, or the more seizures that you have, it's more likely to cause more neurological damage and further reduce cognitive function. So kids with epilepsy are likely to have decreased attention. You've got about a 1 in 2 chance of having ADHD and or significant attention problems. Executive function problems are common, so are glare. Do we glare? She didn't. It doesn't work.
Great boundaries.
Yeah.
It doesn't work. So again, earlier onset, more negative impact. Worse control, more seizures, more negative impact. You're likely to see things like decreased attention, poor executive functioning, slow processing speed, and reduced memory. But those are likely, on average, to be in the average range. Nearly a half of these kids will have learning disorders, most often in writing, and somewhere between 40 and 60% have ADHD. As you would guess, and you don't need to be a neuroscientist to figure this out, that the performance decrements vary according to the location and the type of the seizure focus. So if you have a left hemisphere foci, things like language, reading, writing, verbal memory are likely to be affected. If the focus is in the right hemisphere, visual spatial abilities, things like math and nonverbal reasoning. If the focus is in the frontal lobe, problems with working memory, problems with efficiency, problems with organization. Thing is that in kids who have the onset of epilepsy before the age of 8, they're much less likely to have a specific focus. And so the effects are likely to be involving the whole brain and not localized. And the most common age of onset is between the ages of 1 and 4. So likely to have diffuse effects in kids. And so I have some good news and I have some bad news. We have this medicine, these anti-epilepsy drugs that will help control your seizures. The bad news is that your attention will get even worse. Your concentration will be poor and it will slow your processing speed. In addition to epilepsy, what other sorts of kids are likely to be taking anti-epilepsy drugs? Kids with mood disorders, kids with bipolar sorts of symptoms, and that's a lot. Those kids may be having these negative iatrogenic effects from those medicines as well. I'm skipping that slide. Sickle cell disease. This is about 100,000 people in the United States. About 1 in 500 of those with African heritage. In addition to pain, infection, pulmonary and cardiac complications, you're likely to have some cognitive effects as well. By the time you are 14 and you have sickle cell disease, your chances are about 1 in 10 of having a stroke prior to the age of 14. And as you might guess, there are broad cognitive deficits, both in intellectual ability, memory, and attention, having had that stroke. About 1/3 will have what are called silent infarcts. So this is a brain bleed that doesn't have any immediate symptoms and is detected on medical examination. And so if you don't have a stroke, you might have had one of these silent infarcts. And this is going to affect 85% of kids that have these. And about 1/3 of them are going to have some kind of academic skill delay. And this may be due to the local injury at the site of the stroke, or it can be the chronic hypoxia that contributes to these intellectual deficits. So again, taking a look at this population of kids with sickle cell disease, they usually have lower IQs, but a lower IQ of about 5 points on average, statistically significant, but clinically significant, hard to know. I don't know what the variability is within that. So some are likely to be affected a great deal more. So if you have a higher baseline IQ, you're at a lower risk for behavior problems. Unfortunately, attention and executive functions are going to be more negatively affected by these sorts of insults. Again, going back to that adage, the longer you've had the illness, the longer the condition has been around, the greater the deficits. Only makes sense if you're having repeated sorts of brain injuries and chronic hypoxia. And these kids often are inadequately served by their schools and their individualized education plans. Spina bifida. Do people know what sickle cell disease, I'm assuming you know what sickle cell disease is, what spina bifida is, what renal disease is. Yes?
Could you just explain just a little bit exactly what sickle cell means? Or it's not anemia, sickle cell disease.
Mm-hmm.
What exactly is going on with the child in their body?
Not being a hematologist, I can't exactly explain what these things are, but as it's described, instead of being nice little round, little M&M shaped blood cells, the blood cells are shaped as a sickle, sort of like this, and they carry less oxygen, are more likely to accumulate in the blood vessels, thus creating the likelihood for stroke, and can be hypoxic pain. If you don't get enough oxygen to certain parts of your body, that creates a good deal of pain, usually in the joints. And little guy I saw just last week had been in the hospital for, he'd done very well and had been in the hospital for only a month, got out 2 weeks early after a bone marrow transplant. So his sickle cell disease was so bad that they were going to do a bone marrow transplant so that he would have a better chance of avoiding these sickle cell symptoms. Good news, bad news. You have this treatment that will work, but you got to be in the hospital for 6 to 8 weeks. He is 9? Okay. So spina bifida. Know what spina bifida is? Okay. Kids usually have an intact but low IQ. Their language and word reading is okay, but may have weaknesses in visual spatial or visual motor skills, may have some problems in higher order language functioning. Neuropsychologists may take a look at that and say, might this be a nonverbal learning disorder? Certainly going to have weaknesses in attention, executive functions, long-term memory and learning. A couple of kids that I worked with spina bifida certainly had all of these and some pretty significant executive function problems.
Question?
Yes?
With the spina bifida, depends on the level of severity in regards to lifespan, in regards to the care of what they're going to be doing for, urinary and bowel care and things like that. Some are able to walk, some aren't. Can you tell me a little bit about that?
The question is, depending on the severity of the spina bifida, that has implications for self-care, walking or wheelchair, bowel care, bladder care, etc. The kids that I've worked with spina bifida have been on the more functional end of it. So walking almost all the time, continent with bowel but not with bladder. And as you might imagine, for a guy who's pretty inattentive, doesn't have very good executive functioning, that's going to involve more maternal care. And as this guy gets older and 12-ish, 13-ish, having that enmeshed relationship with mom is not especially desirable. And so that was part of the work that we did, was to try to get a little more distance, a little more independence for this child, so that mom wasn't involved to the same extent, and he, frankly, he wouldn't sit in her lap. So I can't speak to kids who are more involved.
I have a question. Do the shunts, sometimes they get shunts placed in, does that affect their cognitive ability at all when you get shunts placed in their, I guess it goes in the head?
Does shunt placement, which is to drain off extracerebral spinal fluid, affect cognitive function? It does, certainly, when they are not working well or they need to be revised. if they work well, things go better. If they don't work so well, things don't go so better.
So it's kind of on that either or depends.
Yeah, and certainly it's the treatment of choice, but it doesn't always work as well as one would hope, and it's not a one-shot deal nor a cure.
Have to get replaced and infection and all that
Mm-hmm.
stuff.
We used to think that cancer was a death sentence. Outcomes now are much, much better. At least 70% of kids with acute lymphoblastic leukemia, or ALL, survive. And so now this is thought of as perhaps certainly a life-threatening, but perhaps a chronic illness. And there are many cancers, so this is not a very specific slide. But kids who have cancer often have moderate deficits in most cognitive domains. Again, we're talking about information processing, attention, executive functions, memory, IQ, and academics. Their slower rate of acquisition of information increases the gap that they have with peers over time. So they may be missing months of school at a time, or they may be missing days when they have to go into the clinic to get chemo, and so they're not in school as often, and then when they are there, maybe learning more slowly than their peers. If they are treated with radiation, they may be losing white matter over time. And the adult survivors of cancer have some negative effects on quality of life. They're less likely to be employed. Well, maybe the deficits in academic achievement have caught up with them. Slower rate of progress. If you're hiring, do you want someone who's a slow learner? Maybe you do, or maybe you don't. But that may have an impact on why these survivors are less likely to be employed. You're more likely to be single, especially if you're male and a cancer survivor. Out of school, you are working with a medical team instead of the soccer team. You're in the playroom rather than on the playground. And that may lower your social competence. You are embedded in a care team and may be less independent. So these are probably not attractive date bait. And certainly lower quality of life. So kids with ALL, as I said, the survival rate's over 70% now. Most of these survivors have good long-term outcome. And in this study I'm citing had a whopping 30 subjects. But they had some problems with working memory, although it's still average, and had pretty intact executive functions. Those who did have lower executive functions were less able to retain information, to think flexibly, to self-monitor, and less able to use these skills to cope effectively. And not surprisingly, had more behavioral problems. Okay. Now, if you recall, Frank had end-stage renal disease. So renal failure, if it's acute, can result in rapid, florid failure of cognitive functioning. And very early onset can produce these severe intellectual delays that we talked about in infants and toddlers. Older patients, they can have deficits in verbal reasoning, perceptual reasoning, and immediate recall and memory. When they get into school, below grade level achievement in reading and writing is pretty common. Treatment for end-stage renal disease is kidney transplant, and the data on transplant are a bit mixed, as it is with most of this literature. Sometimes it will help cognition. Certainly, kids who have been evaluated pre-transplant to post-transplant will show some improvement. But again, compared to healthy controls, and not as good. These kids who are transplanted usually look better cognitively than controls who are still on dialysis. So transplant likely to improve cognitive functioning. But again, here you look at statistical significance and clinical significance. And while the statistics look good, the clinical significance may be lacking. And that may be because of the bad news. The good news is we have this treatment. It's effective. You're no longer going to die because you have no kidneys. It's not a magic bullet. You are trading this life-threatening illness for a state of chronic immunosuppression. And those medicines will have some negative cognitive effects, as will the steroids that we've mentioned earlier. So what you may be gaining in terms of improved renal function and the cascade that flows therefrom may be offset by taking these immunosuppressants. The good news after the good news and bad news is that this may stop further deterioration in your cognitive functioning. So let's look at Frank. When I evaluated him, his intellectual functioning was in the low range, and especially with novel nonverbal problems. So his perceptual reasoning index was quite low. He, not surprisingly, had a very hard time with handwriting, had a very difficult time understanding concepts, and his vocabulary was at the 10-year level. How old is Frank? Anybody remember? He's 16. So it looks like a 16-year-old. Kids with renal failure often look much younger than they really are, but he looked like a 16-year-old. And if you're talking to him and giving him instructions about his care and about the sorts of diet that he needs to adhere to, consequences of taking his phosphate binders, consequences of drinking too much fluid, like a 16-year-old, how much of that is going over his head? Probably quite a bit of it. His verbal memory was okay, so that was good, and he could pay attention adequately. Some effects on achievement. So when Frank went back to school, what was likely to occur? Well, not surprisingly, he was at increased risk for some academic problems. 30 to 40% of kids with chronic illness have school problems. About a third of them are in special education, and 25% repeat a grade. the way kids function in school varies according to the type of disease they might have. This overview comes from a meta-analysis of more than 900 studies, and we've got more than 100,000 children and adolescents combined in this meta-analysis. Diseases including cancer, asthma, diabetes, arthritis were the most prevalent diagnoses. And these researchers found that the largest effects were from those, not surprisingly, largest effects were those that had profound effects on the nervous system. That is cerebral palsy, spina bifida, and sickle cell disease, interestingly, had the largest negative effects. Moderate effects, again, those illnesses affecting the brain with migraines and epilepsy. Contrary to what we've said before about the effects of age and duration of the illness, they didn't find them and found lower functioning in minority students and third world students. And the median duration of illness was about 6 years. So they weren't just looking at newly diagnosed kids either. So pretty negative effects on academic functioning. Lots of kids with epilepsy, about a third, are going to be in special education. About 40% have repeated a grade. And problems across the board are pretty common: reading, spelling, and math. And this is not merely the effect of having a chronic illness, because you can compare these kids to asthma controls and their achievement's going to be worse. So again, chronic illness is affecting the brain, probably worse cognitive outcome, no surprise. Well, let's look at Frank's achievement. Overall, he had difficulty achieving in school. He had particular problems in math, especially math reasoning. His reading comprehension was below average. He had difficulty with timed writing and with abstract thinking. So what might we suggest to help Frank and other kids with chronic illnesses in school? One might be a school reentry conference. This might be where you come in. We have a department at Phoenix Children's Hospital that's attached to One Cool School, which is our in-house school. But the job of these reentry specialists is to go with kids if they wish, or prior to kids if they wish this to not be involved, and go and talk with teachers, may talk with kids in the classroom about what this child has been through and what to expect now that they're back in school. So if you do one of these reentry conferences, you might be giving basic facts about the illness and its treatment. You may be telling kids that this illness is not contagious. You are probably focusing on the ways in which this child, although they have a chronic illness, is pretty much that same child. Certainly has more things in common with their classmates than they have differences. Talking with the school about planned absences if there's a chronic course in which this child needs to go into the hospital for treatment, and we can plan this out in advance, do so in a thoughtful way. And anticipating negative peer reactions. Certainly a very, very important thing for kids with chronic illness is to feel accepted by their peers. One of the other patients I'm working with she has diabetes, she has Addison's disease, she has fibromyalgia, orthostatic tachycardia, and depression. And I started working with her when she was, I think, 13. And when they came into the intake, they said that one of the negative life events that she had experienced was at church. I mean, where do you go for acceptance and comfort and help? You go to church or you go to your religious group. But this was a problem because the kids in her youth group were saying, well, we don't want to hang out with you because you have diabetes, and that's God's punishment for your sins. Well, what sins? We don't know, but you must have committed them because you've got diabetes. And so her mom, who's pretty assertive and proactive, intervened and went to the religious leader and said, hey, can you intervene with this? And the leader said, no, because it's obvious that this is God's punishment. So they left that religious organization. But here's an example of how peer problems and negative peer reactions is probably having a greater impact on this child's well-being than are these other illnesses. So another thing that you might be involved with is advocating as necessary for special education services. And most of these kids with chronic illnesses would be considered under the category other health impairment. And you may help in developing that child's IEP. So other health impairment is part of IDEA, which is the special education law. And as with most of these laws, they have explicit definitions, like this one. Another health impairment is a health impairment that limits strength, vitality, or alertness. Leaves a little something to be desired in terms of its specificity. But another health impairment is a health impairment that limits strength, vitality, or alertness due to chronic or acute health problems. And that impairment adversely affects a student's educational performance. So if you have a child with a chronic illness that impairs their strength, vitality, or alertness and has a negative effect on their academic achievement, you might want to consider them for special education. Probably going to need a physician's note documenting what the problems are and an assessment showing the negative impact on performance. So obviously you can't provide the physician's statement, but you may be providing some of that assessment that's going to show the negative impact of this illness on that child's performance.
Would that be separate from the psychoeducation testing, or would that fall into if you're working with the school and the school psychologist advocating for the psychoeducation? So that almost seems that would be different from illness. I just think that their test results might end up being different. And then the school psychologist comes back and says, well, they don't need a 504 plan or an AEP plan because psychoeducation testing looks just great. And then the parents have to advocate even more, but this is falling into a different spectrum. So which type of testing would you end up doing to have to be appropriate? Well,
again, they have to have the health condition. It's got to be affecting their strength, vitality, or alertness. And then there has to be some documentation of how that impairment has affected their school performance. So you would be doing probably a record review, and you'd probably, if this is not done at school, you'd be doing a record review, and if there's a before and after, before illness and after illness, checking out the grades, and some assessment of academic skill, at least. Certainly would, given the broad range of cognitive functioning that's impaired by these chronic illnesses, probably memory, probably intellectual ability, probably executive functioning, probably visual spatial and visual motor assessment. And if there are no problems there, this child's not going to need special education services. But the chances that there's some impairment there is pretty good. And if it's a new onset illness, you've got a baseline to compare to, because we know that generally, the 2012 study notwithstanding, the longer kids have illness, the worse cognitive effects it's going to create. And certainly, I see lots of kids in my practice who aren't evaluated by their school. They don't have a school psychologist. They're in a charter school, or we don't trust the school. And maybe that they're less conversant with these kinds of health conditions and the cognitive factors that are affected. So let's assume that schools have seen the negative effects of this illness and want to help. How might they do so? Well, they can do so by adjusting assignment lengths or deadlines. They can reduce the course load or the length of the school day. Anybody in here, and I will volunteer myself, had a long-term illness? Yes. Even when you're better, pretty tiring. It takes a long time to get one's endurance back. So reducing the length of the school day is a very reasonable accommodation. Go in for one class. Go in for one class plus lunch. Go in for 2 classes and lunch. And gradually build that schedule up as the child's endurance increases. If kids are in the early grades, having a portable and systematic reading instruction that can follow them into the hospital, if they will be there for a long time, would be important. Hospital like Phoenix Children's has its own school. So kids who are there for a long time can go to school and not fall as far behind with their learning. Increased use of technologies such as computers, Skype. Did anybody see, what did that guy have? He had an immunodeficiency, so he couldn't really go to school because his immune system was suppressed. So he had a robot go to school for him.
I saw it in the Today Show.
What do you recall?
It kind of went around to the different classes for him while he stayed at home and was able to see it through, I don't know if it was I'm assuming the computer, and learn that way. That's all. It was a while ago that I saw it, but it pretty fascinating. It was like on wheels, and it
Yeah.
just went around.
It had a video monitor, sound, and he could remotely control the movement of the computer through the school.
Yeah.
It was remarkable, actually.
Cool.
Yeah.
And so he's also communicating back and forth with teacher and his peers, so that's a pretty outstanding use of technology. But less sophisticated, using computers, using organizers, using smart pens, word processors. Sometimes those technology fixes have a very, very significant effect on how kids do in school. Flexibility in the rules. Okay, nobody wears a hat in our school except you, because you don't have any hair, and so you can wear a hat. And provision for a quiet place to rest or just gather oneself during the day. Those are things that schools might do to help. And does anybody want to take a break? Should we plow ahead? Plowers, okay. Your endurance is good. All right, we will do so. Many of the illnesses that we've talked about have negative effects on executive functioning. Certainly executive functioning important for success at home and school. And so often I hear from parents and sometimes from teachers that kids are just not responsible. They need to be more responsible. They need to be more mature and just grow up and do what they're supposed to do. And they have this increased burden, not only of getting their lunch and their homework to school, but they have this probably fairly complex medical regimen that they need to be responsible for. So it's important for kids with chronic illness to support them in their executive functioning. So if you can arrange for accountability 2 or 3 times a day, and this does not mean shame and humiliation, but it means let's keep you on track and not let you get too far off, and give you some help with organization, getting started, making good plans, taking a look back at what you've done and seeing how that measures up to what we want, and keeping all those steps in mind. So it might be important to find an organization coach. This might be the school counselor, it might be the special ed teacher, it might be the classroom teacher, it might be an older student who's helping out with the younger kids. But an organization coach. Let's make sure you get all your homework turned in. Let's make sure you got all your assignments written down. Let's get all your notes to go home. Make sure you have all your books that you need to study. How about initiation? Kids with poor executive functions are often overwhelmed by the amount of things that they need to do. So teach them how to eat an elephant. Does anybody know how to eat an elephant? One bite at a time. So here's this huge task. Let's figure out what bite we're going to take first. And kids usually like that analogy. If it's hard to remember things, what do you need to do? You need to use a memory prosthesis or a memory aid. And you need to know how to use it. And then you need to use it. But if your memory is not very good, you might forget to use it. So that's the challenge with using memory aids. One, learning how to use them and using them consistently. So this is where the accountability or the organization coach comes in. to make sure that these memory aids are in place and are being used. Kids who need to self-monitor better can be encouraged to predict how they're going to do before they do it. So how many items do you think you'll get right on this test? How long do you think it will take you to write this essay? How many pages do you think you can write today? Well, okay, let's write that down, and then we're going to go back and check to see how accurate you were. And kids who have difficulty planning can be encouraged to file a flight plan. Okay, a flight plan says, I'm going to take off from this airport at this time, I'm going to fly this route, and I'm going to land at that airport at another time. And so that's basically what you want kids to do. Here's where I'm starting, here's how I'm going to get there, and here's where I'm going to arrive. So encourage kids that need planning help to file a flight plan. Well, how can parents help? One of the biggest things to do and one of the hardest things to do is to adjust expectations. And there's a certain amount of grief and loss involved in this process. This is not what I bargained for. This is not what I signed up for when I thought I would have a child. Parents can be helpful by providing additional structure around homework. And while not a good idea for parents to do the homework for their kids, they can manage the space, they can manage the time, they can help clear the desk, have a good office in which kids can work, and they can be helpful that way. Parents, Henry.
Yeah, so
Hi.
what if there is I guess, impairment in their cognitive deficit, and it's like a later onset, so they are, like you said, performing well, but they want to do well, but parents are understanding, like, so what do you do with that child to let them know that their performance may be lower than what it was in the past, but they're just so determined to achieve higher?
So the question is, if there's a later onset of the illness, kids are used to performing at a pretty high level, so are their parents. And with the onset of illness, they don't do as well, but are determined to reach that former level of achievement. Sometimes education, we anticipate that this is the course of this illness. These are the effects. It is likely that you will run into these obstacles, and you're a very determined person. Therefore, we know that these are some of the things that you can do, and you being a determined person will probably do them very well, that can get you back on track. And so that would probably be my first strategy. And if there was ongoing frustration and self-esteem hits that came after, I think I'd talk about what that meant and what achievement meant to their identity, other aspects of identity that aren't affected by this. Is it possible to move towards those things that this child values in spite of the challenges they face? Do they have other strengths that are valued by others? And maybe address some of the those grief issues of these are the things that I've lost. You know, I used to be on honor roll. Now I'm not. Many families, many parents have lots of their own burdens, lots of their own work, may not have time to provide the degree of tutoring and homework assistance and executive function support that we would wish for, and may be able to provide tutoring if they can't do it themselves. If the rationale goes, there's only so much I can do, somebody else can do the tutoring, I'm going to direct my energy at managing this child's health condition. Let's get a tutor. Let's have a tutor at school. Let's have an older child come in and help our child. That can be a great relief to some parents. More frequent meetings with the teacher is likely, and they're probably going to give help with homework. They might read things aloud. They might be the secretary, or they might be the scribe for a child who's having problems with visual motor function. Can be a proofreader to help with homework. So this is directed at my physician colleagues, but these are things you might, in your primary care setting, might be talking with physicians about for kids who you are sharing their care. Important to physicians to understand that cognitive factors play an important role in that child's quality of life. You can also encourage them to make appropriate referrals. The Emily Center, Emily Anderson Learning Centers at Phoenix Children's Hospital is a wonderful resource for parents of kids with chronic illness. You don't need to be a patient at Phoenix Children's, but they have lots and lots of resources for kids, for adolescents, for adults. They have information, a growing amount of information that's available in Spanish. And the people who staff the Emily Center, that's what they want to do. They want to get you the information you need. That's their mission, and they do it really well. Anybody know what Section 504 is? Henry? Do you know what Section 504 is?
Yeah, that's providing them some accommodations in school.
Okay. So Section 504, do you know how it's different from IDEA and special education?
That falls under the American Disabilities Act?
It is very similar to. Section 504 is part of civil rights law. It says that you cannot discriminate against people with disabilities and must provide reasonable accommodations for that disability. And that's different from special education. So, this is providing protection for people with illnesses or conditions that, again, here we have this fabulous definition, very precise and quite understandable. These conditions substantially limit a major life activity in terms of the manner, duration, or conditions under which they perform that activity, compared to people in the general population. So if your child, your patient has this health condition that's substantially limiting this major life activity, such as learning, such as walking, such as breathing, working, they may be eligible for protection by the way of accommodations under Section 504. When you get to be an adult, you're covered by ADA, or Americans with Disability Act. So the purpose of 504 is to provide these accommodations that are going to remove barriers. Okay? You'll often hear the word, or the phrase, level the playing field. Accommodations are meant to level the playing field so that the outcome is neutral. It's not to help people and have them with optimal performance, but it's to remove these barriers so they can get to what they need to do.
It still stay somewhat college bound, per se, is how it was described to me. Like it's like how we may take stairs up to the second floor, they take a little ramp up to the second floor, and then the IEP almost changes the curriculum where there be 504 keeps you still on track with going into college and doing all that, where the IEP could make it more challenging. That's how it was described.
I think 504 would not address college. You said it's outcome neutral.
Right.
We are not trying to get you to college if you weren't going to college before.
Right.
If that's your goal before, that's fine. We have nothing to do with that. We just want to get the obstacles out of your way so that you can do what you had intended to do. And the stairs versus the ramp is a sort of a classic analogy. If you're in a wheelchair and there are stairs to get up to the schoolroom, you can't do it. You might be Stephen Hawking. You can ace the curriculum, but if you can't get in there, you can't pass. So we're going to give you a ramp. That's your accommodation. Doesn't do anything to the curriculum. It's just it's removing the barrier to get you in there. What you do once you get in there, we're not trying to improve your outcome. Special education, on the other hand, is. Okay? So again, we talked about how some of these protections might affect and benefit, or shouldn't have said benefit, remove obstacles for kids with chronic illness. If you shorten their assignments or give them more time to complete them, that is a reasonable accommodation to reduced endurance. If you have note takers or computers or using robots, those might also be reasonable accommodations. I don't know that every kid with chronic illness is going to get a robot. So a robot may not be a reasonable accommodation. Or a separate room for testing. If you're distractible, if you need to get up and walk around because it's difficult to sit, separate room for testing might be a reasonable accommodation. So here, again, this slide is directed towards physicians, but physicians may not be as dialed in to 504 plans as we may be, and physicians may rely on you for some of the documentation, at least in terms of consultation about what might go into this. So you're not going to be making the diagnosis of the physical health condition. You may be making other diagnoses, such as ADHD or depression or one of those, anxiety, one of those diagnoses that can add to the documentation for this plan. Documenting the child's limitations in mobility, manual dexterity, communication, information retrieval, or endurance. Some of these you may have input into, others I think it's less likely. But you must document, or the physician must document, how's this child limited? And how do these limitations affect their ability to perform in school? What would be nice then is to add how might this child be accommodated? Is this child in a wheelchair? What is the passing period between classes? Is it reasonable to expect this child to maneuver this wheelchair through a crowded hallway and get to class on time? Maybe not. So that would be a reasonable accommodation to give them more time to get between classes. Kids who have effects in manual dexterity are going to have problems in writing. Is it reasonable to provide an alternative demonstration of mastery? Are they going to need help hanging on to things instead of dropping them? Are you going to relax the writing requirements for these kids? Children with communication difficulties may need help with expressive and receptive language. Frank, for example, probably going to need simplified instructions. Kids who have information retrieval problems are going to need instruction in and monitoring of their use of memory aids. And endurance, pretty hard to assess. Does this mean endurance for sitting? Is that difference from their endurance for running the mile in PE class? Probably. So we talked about 504 on the previous slide. This is back to the other health impairment, which is different. Other health impairment is a category under special education, same as learning disorders, traumatic brain injury, autism, speech-language impairment, mild and moderate mental retardation. And the qualification is a little different. It's looking for when this disability adversely affects education and special services are required for the child to receive an appropriate education. As you indicated earlier, very likely that part of the special education is going to involve a revision of the curriculum and the methods or ways in which that curriculum is administered. So you may be going from your homeroom to a resource room where there's a smaller number of kids getting specialized instruction at a lower level of the curriculum in that class. And things like diabetes, epilepsy, ADHD, arthritis, cystic fibrosis, HIV, these are all examples of other health impairments. And learning, manual tasks, working, breathing, running, walking, all of these things are major life activities for which there might be a functional impairment. Do we glare at people who are leaving early?
Yeah, we can do that too.
Okay. All right, well, we talked about school. This next section pertains to kids managing their illness. And these regimens are often very complex and pretty stressful. I'm sorry. Got to take this. Yeah. Uh-huh. This is Dr. Barton, yes. Center for Disease Control? Oh. Oh. Okay. All right, I'll let them know. Yes, thank you. Sorry for the interruption. That was the Center for Disease Control. They wanted me to inform you of some good news and some bad news. The bad news is that they now know that you all have a serious illness. It's pretty nasty, can have some very serious consequences, and it's probably going to change your life forever. But I have some good news. Because there's an effective treatment for this illness. It is pretty expensive, though. Takes a lot of time. It's painful. And when you do it, your friends are going to make fun of you. So, now, all those who'd like to sign up for this treatment, please line up over here. Yeah, go ahead. Go ahead. Why isn't anybody lining up? This is an effective treatment for this illness. Okay. Well, it's those things that are going through your head about expense, time, pain, and the negative social impact that many kids with chronic illness have to face with their medical regimens. In addition, there may be some cognitive factors that are making this adherence to these regimens even more difficult. Because many of these chronic illnesses affect the brain regions that underline the skills that are necessary to manage these regimens. Some researchers in this area have said the importance of cognitive variables in diabetes management cannot be underestimated. So we've got important stuff. And what are the chances that Frank, in his, anybody been to the physician lately? How long did you get with that person? 5 minutes. 5 minutes, okay. 5 to 7 minutes. Okay. What are the chances that in the 5 to 7 minutes, and he was with a specialist, so maybe it was 15, that he's misunderstanding some of the crucial information that the physician is reporting to him? Pretty good. What are the chances that, Frank, we've been noticing that some of your tests have come back, and your phosphate levels are really quite high. Can you help us understand that? No. Well, how are you doing taking your phosphate binders? Well, good. Except for the weekends. Oh, well, why is it different on the weekends? Well, because I'm over at my brother's house. Okay. Well, why is that different? Well, I don't have my phosphate binders at his house. Really? Why not? I don't know. So, not very good problem solving. So, brother was very happy to have a separate bottle of phosphate binders at his house and to make sure that Frank took these when he was spending the weekend. Poor decisional skills, and these things all lead to non-adherence. And this is the norm. Depending on what study you read, it might be anywhere between 34% and everybody. Non-adherence increases over time. So this may be one of the reasons that the longer you have the illness, the worse the cognitive effects. in general. And the worse the control, the worse the cognitive effects. So if you're not adherent, you're not going to control your illness as well. So with these kids who don't have good information, it might be important to get across to them and test them frequently. What are signs that your condition is getting worse? How will you know? For those kids who don't have very good decisional skills, it might be important to equip them with the ability to make decisions about when emergency care is necessary. So what's going to predict successful management? Well, kids who are smarter, right? They're going to do better. Not so much. Why not?
Well, you mentioned that if there's a social impact, there's a support system impact. So I would think it's more holistic than...
Memory is a better predictor than IQ or achievement. And the ability to represent what's going on with you, what are these internal states, and to be able to accurately represent those are better predictors of good management than our IQ or achievement. Kids who have more knowledge about their illness and their treatment might have better control, but might not. Knowledge is not directly related to control. It seems to be that knowing how to cope with the illness and manage stress that are associated with the illness are the mediators of this knowledge-control relationship. So certainly this is where we may come into play in the medical team, is helping kids cope with illness and manage stress. And there may, yeah. So what are you supposed to do about it? Well, you can help kids have better knowledge. Again, in 5 to 7 minutes, maybe 15 if you have a specialist. Knowledge probably not great. Reviewing the benefits of adherence. This is one of those, what's the benefit of a phosphate binder? Well, the benefit is 20, 30, 40 years from now, your bones won't crack because the calcium has been leached from your bones by these phosphates. Okay, so I'm supposed to take these giant pills that make me look like a drug addict in front of all my friends for something that's going to happen 20 years from now? Well, anticipate some of the barriers. You'll be going to your brother's this weekend. Will you be taking your phosphate binders with you? Be consumer friendly. Simplify, simplify, simplify. Encourage parental supervision. This is not a popular intervention, either with parents, sometimes, but usually with adolescents. And provide prompts. Our hepatologist, also known as a liver doctor, recently published a study whereby they gave patients cell phones. Here, take this cell phone. We will be providing you texts at the time you are supposed to take your medicine, and if you don't, and we'd like for you to respond that you've done so, just by sending a brief message. And if you don't, then we'll be calling you. And if you still don't, then we'll be calling your parents. And so this was a pretty high-tech, but also pretty attractive because, hey, I get a cell phone. And a pretty effective way of providing prompts to kids to take their medicine, and it did improve adherence. So rewarding adherence, and here you can help parents engineer that kind of intervention. Punishment, I think that's going to be a hard sell. Kids are punished enough by their illness and their regimen, so might not want to go there. But teaching self-management strategies, how to use memory aids, monitoring memory aids, tweaking the use of memory aids, helping kids manage anxiety, regulate their emotions, consulting with parents, consulting with schools, consulting with school nurses, consulting with physicians, and referring kids for psychotherapy who do have adjustment problems and are have family conflict, anxiety, depression, or other sorts of conduct problems. Okay, well, what about Frank? What did we decide to do for him? Well, we wanted to improve his adherence, and so given his lower verbal comprehension, we instructed all those on the medical team to simplify their explanations. We wanted to anticipate problems. Okay, you're going to your brother's this weekend. Let's get some of this medication over to his place before you get there. We also, let's see, he was very nervous about transplant. And he said, well, you know, when I get a transplant, I think that's going to be tough. I think I'll just spend the rest of the school year in the nurse's office. Oh, well, I guess you could do that. What else might you do? And we worked on that problem and rehearsing some of the solutions and got to talking about what sort of kind of a medical miracle it would be for him to have a transplant, and wouldn't that be kind of attractive, and wouldn't he be sort of a celebrity? And you know, his eyes sort of widened, and he said, "Yeah, that'd be really cool. I'd get on the announcements my first day back at school, and he'd say, 'This is Frank, and I'm back.'" So, you know, a pretty far cry from the guy who was going to stay in the nurse's office to a guy who's making announcements. Excuse me. We needed to manage his anxiety and improve his assertiveness. "This is Frank," when he got back to school after his transplant. Wanted to consider an IEP for him. He was probably going to need resource help in math and some accommodations such as simplified instructions and use of a keyboard, word processor, laptop sort of thing in the classroom. Okay, so we are in the home stretch. Not bad. So children with chronic illness can have subtle effects on their cognition. These can vary to profound deficits. Most of these effects are moderate, and most children do okay. Even under these very trying circumstances, most kids are going to do well. These effects can and very often do interfere with their disease management. And physicians can help by thinking about the cognitive factors in their treatment plan, even cognitive factors for diseases that don't involve the brain. They can document their diagnosis and provide that documentation of functional impairment and limitations to schools, and work towards tailoring the medical regimen to account for some of these cognitive deficits. And those are some of the references, and that's that. Okay. So, thank you for listening and remaining awake, mostly.
I appreciate you coming in.
Well, thanks very much. Any questions? It's either a very good sign or a very bad sign.
Kind of a question, observation, your thoughts about. And it had to do with the actual situation in my family. I have a brother who had a daughter with cystic fibrosis. And I was struck by the absence of attention on them as parents in terms of dealing with a disease they were unfamiliar with, okay? And the absence of resources that were made available to them regarding how they could take care of themselves or educate themselves about the disease. Your thoughts about that, and how important you think that may or may not be in dealing with children with chronic illnesses?
Shocked. Particularly with CF, a very intrusive, life-changing for all in the family, certainly affecting the hopes and dreams that those parents had for that child. And I would say that was not good care for neglecting the parents and helping them deal with the extreme stressors that they're going to have to cope with to deal with this child's illness. The treatment is daily, several times a day. It's highly likely that that child's going to be hospitalized many times, and often for days or weeks at a time. This is a severe financial stressor. So if you're not helping those folks deal with all of that, it's not very good care. Certainly and that's one of the reasons that the Emily Center came to be, was that Emily's parents couldn't find the information that they wanted. And when she died, they said, this is what we're going to do in her memory. And we're going to start this center. And again, it's really a wonderful gift that they gave Phoenix with this resource center. So, let's see. So that's the kind of short answer.
I think encouraging parents to take time for themselves, because oftentimes their world revolves around their child, and that taking those moments out of their week can sometimes seem like too much. Like, I don't have time to do that. I'm doing this and attending to the bills and the stuff coming in the mail and my child's treatment that occurs throughout the day, and then I still need to do the laundry and wash the dishes, and it's just the amount of stressors that are there just from the day-to-day life that I think, whether it's the psychologist or the physician, really advocating for the parent for their own self-care, I think is really, really important.
For newly diagnosed kids, I will sometimes talk about the new rules. There's rules for taking care of acute illness. There's new rules for taking care of chronic illness. And take care of acute illness, sort of all bets are off. Life, as we know it, stops for, a day or two or three, and then we get back to normal. Not that way. There's going to be a new normal when you have a chronic illness, and you have to have new rules. One of those rules is you have to let this child's care, at least some of it, be in the hands of their treatment team, and you need to get back to doing the laundry, taking care of yourself, and getting back to work, probably in a different way. Other questions?
I've noticed that I've had a couple of children with spina bifida, either, like we were saying, Dr. McCain, that I've seen both spectrums of parents minimizing their children and their abilities, and they're normal, they can do this, and the kids are really struggling. Or I don't want to say maximizing, but also not, how can I explain? Being involved, but being really protected, being really involved. These kids are coming into adolescence and they're really wanting to do their independence. So I found that doing a lot of family counseling with that, with my client, not just my client, but with the parents, and trying to get an accurate of where they're at, and trying to have mom and son, or parents and daughter, to really come together and work on this. Otherwise, because both these kids are coming to adolescence, and it's really difficult. They really want they're both adolescent boys, and they really want their space, and one mom could be pretty overprotective. So
Yep.
when my kiddo, who's 8th grade, he's like, I don't want an assistant this year because it's awkward around my friends, and so, but he's got very limited ability with his hands, so his occupational therapist at school has been talking about having software where he talks to computers and notes are taken. So that's something that he's been really wanting, and he's been talking to the school, social worker about that.
Well, and those, any parent, any child, any adolescent is going to have those same negotiations of independence and dependence, and it's just magnified, and the consequences or the outcomes of those negotiations, I think, are potentiated with all these health complications, and certainly you've got opposing developmental forces. I want to be independent versus I want to make sure you're taking care of yourself, and those present some real challenges towards adolescence. So they're lucky to have some help with that.
I was also going to say for therapists in the room that if you've ever had the opportunity to be in an IEP meeting or a 504 plan meeting, and if you have a good relationship with parents and they invite you, it's your testimony and your experience or your work with the child, the client, brings a lot of insight to the school. They don't know exactly what is going on with these kids, what their issues are, and I've been part of that, and the school really values kind of what's going on with your clients, and they really take that in assessing what they can provide for the kid. You're really advocating for the child and the parents. Sometimes as parents, if you've ever been in an IEP meeting, they're kind of lost in what's going on, and so if you can help advocate, that's really, if you're fortunate enough to be involved, it's really good.
Well,
Okay.
thanks again, and looking forward to your return.
Thank you.